Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Impact of Specific EGFR Mutations and Clinical Characteristics on Outcomes from EGFR tyrosine kinase inhibitors versus chemotherapy in EGFR-mutant lung cancer, a meta-analysis, by Chi-Hoon Lee and co-authors. My name is Jeff Oxnard, and I am an Assistant Professor of Medicine at Dana-Farber Cancer Institute and Harvard Medical School in Boston, Massachusetts. My oncologic specialty is lung cancer and translational research. This meta-analysis compiles data from 7 landmark studies randomizing patients with advanced EGFR-mutant lung cancer to combination chemotherapy or an EGFR tyrosine kinase inhibitor, or TKI. Trial-level data were available from 3 of the trials, and patient-level data were available from 4 of the trials. Using this rich data set, the authors asked a fundamental question. Within a larger population of lung cancer patients with common EGFR mutations, exon 19 deletions or L858R, are there some who gain more benefit and some who gain less benefit from receiving an EGFR TKI? Importantly, the consistent lesson across each of the trials they analyzed is that treatment with a first-line EGFR TKI, be it gefitinib, erlotinib, or afatinib, is better than treatment with first-line doublet chemotherapy in patients who harbor EGFR-mutant lung cancer. This result is maintained across all subpopulations studied. However, among the different subsets studied, they hypothesized there would be areas of heterogeneity where some populations benefit to a greater degree from EGFR TKI than others. Take, for example, the 2 most common subtypes of EGFR mutations, exon 19 deletions and L858R mutations. It was first shown in 2006 by Greg Riley and colleagues that lung cancers with exon 19 deletions have a longer progression-free survival on EGFR TKI than lung cancers with L858R mutations. This meta-analysis by Lee et al. Now quantifies this difference with greater clarity. Studying over 1,500 patients, they find that the hazard ratio for progression-free survival benefit from EGFR TKI as compared to chemotherapy is 0.24 for exon 19 deletions and 0.48 for L858R mutations. This means that when you start a patient on a first-line EGFR TKI, those patients with an exon 19 deletion on average have a 50% greater PFS benefit over chemotherapy as compared to those patients with L858R mutations. Interestingly, this heterogeneity also bore out in some subsets defined by clinical features. Never smokers had a 36% greater PFS benefit from EGFR TKI over chemotherapy as compared to current or ex-smokers. And women had a 27% greater PFS benefit from EGFR TKI chemotherapy as compared to men. All of these differences the investigators detected were maintained when adjusting for covariates in a multivariate analysis, and differences generally were maintained in a sensitivity analysis across trials. So what do these findings mean? I see 3 implications. First, these findings have implications for drug development. These covariates of EGFR mutation subtype, smoking history, and gender should be considered when planning studies and interpreting results. For example, a trial that studied more never smokers with exon 19 deletions might be expected to have more favorable outcomes with EGFR TKI compared to a trial that included more smokers and L858R mutations. In that vein, randomized trials of first-line EGFR TKIs should consider stratifying based on these variables. Second, these findings provide context for the recent publication describing the combined survival analysis of 2 trials of first-line afatinib versus chemotherapy, LUX-Lung-3 and LUX-Lung-6. In that combined analysis by James Yang et al., a significant improvement in overall survival was seen in patients with exon 19 deletions treated with afatinib rather than chemotherapy, but not seen in those with L858R mutations. And yet, in this meta-analysis by Lee et al., it seems clear that patients with exon 19 deletions broadly gain more benefit from EGFR TKI over chemotherapy. While this meta-analysis reports on progression-free survival and not overall survival, my suspicion is that the survival outcomes in the afatinib studies may be more related to the favorable outcomes from treating exon 19 deletions with EGFR TKI rather than some unique effect of afatinib. We look forward to results from the randomized trial of afatinib versus gefitinib to offer some clarity on this. Finally, the study findings may have meaning for our clinical practice. Overall, the principle that mutation status trumps clinical characteristics is true. All patients with advanced lung cancer harboring EGFR exon 19 deletions or L858R should receive first-line EGFR TKI. However, we may need to consider the possibility of biologic heterogeneity when we plan our follow-up for these patients. In a patient with an exon 19 deletion or a never smoker or a female, EGFR TKIs may more reliably lead to a dramatic benefit. But in a patient with L858R or in an ex-smoker or in a male, there may be a slightly lower likelihood of dramatic benefit and a relatively greater chance of benefit from chemotherapy. Maybe in these patients, we should keep a close eye on the patient and the cancer. If such a patient does not appear to be benefiting from an EGFR TKI, an early switch to chemotherapy could be appropriate. Overall, we as clinicians need to keep our eyes open for outliers, understanding the potential heterogeneity within any clinical presentation. The squamous or small cell lung cancer in a never smoker might in fact be an EGFR-mutant lung cancer in disguise. The ALK-positive lung cancer in an elderly smoker might be a false positive, and some EGFR-mutant lung cancers may not gain as much benefit from EGFR TKIs as we anticipate. Hopefully, with the additional advances in clinical genomics, we can come to better understand this heterogeneity and use it to guide the care of our lung cancer patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.